There's like 2 people awake. Is anybody awake? Good morning. Oh, I saw a hand up. I appreciate you back there. Thank you. So, okay, you guys, really quick, before we get started, I have to do some reminders. That's what they tasked me with. So first of all, thank you for being here and attending this session. Second of all of you guys are passively CE tracked just by walking in the door, so you're good there. Your session notes can be accessed through the Zomedica group app, and no flash photography or unauthorized recording of the session because it scares the speakers. So, anyways, it's my honor and pleasure to introduce Dr. Shadi Arifich.
Thank you, Nicole. All right, good morning, everybody. Everybody hear me okay? All right, let's do it. So I'm Dr. Shadi Arifich, and we're going to be talking about acute, non-traumatic, spontaneous hemoperitoneum in dogs. The proceedings that Nicole just mentioned are very thorough. They accompany the past 10 plus years of medical literature in PubMed, so that's meant to be much more of a reference. This hopefully will be more clinical, practical application to hemoabdomens. How many folks here are veterinarians? Nice. How many folks here are technicians, nurses? Okay, all right, great. And how many people cut hemoabdomens in their practice? Okay, good number, good, all right, perfect. So a little bit about me. I graduated from Cornell University in 2006. I completed my 1-year general internship at Angel in Boston. I then completed 2 surgical internships followed by a surgery residency, became a board certified surgeon, and then from there, long animal veterinary specialist, I left New York after almost a decade of practicing at that facility, went out here to Las Vegas, practiced at the specialty center here in town, did that for about 9 months, then went ahead and did some locum work. From there, I moved to the Bay Area, managed 3 hospitals in Silicon Valley, 24/7 on call for surgery, and then I became part owner of a hospital that we converted from overnight and weekends to 24/7 multi-specialty. I was in charge of oncology, surgery, and internal medicine, and then currently Vet Triage, which is a telehealth platform that I'm happy to talk about if anybody has questions regarding. Here's our outline. We're going to go through a whole variety of features here. We're going to kind of go through the basic stuff fairly quickly. I want to focus on more clinical applications of hemoabdomen from a surgeon's point of view. If you have any questions, feel free. I prefer this to be an open discussion, and I realize, of course, that there's many ways of handling hemoabdomens, so I'd love to hear your thoughts on any of these topics. So basic anatomy of the spleen, we're all familiar with. The cranial abdominal cavity, and the position of the spleen will vary depending on the breed and what the spleen is doing. Of course, what we care about when we're talking about hemoabdomen, specifically splenectomy, is the vascular supply to the spleen, and so, of course, we want to make sure that we're familiar with this anatomy before pursuing the surgery. For those of you who do cut these cases, you'll often see that this becomes just a mess in surgery, and so a lot of times the goal is just to stick by the spleen anyway when you're trying to remove it, but it's important to recognize what the normal anatomy is. Here's some more schematics about the vascular supply. They're showing its proximity to the gastrointestinal tract, and again, the goal of surgery, if you're talking about a splenectomy for a splenic mass or any other splenic pathology, is to stay as close to the spleen as possible, so you're not interfering with the blood supply to the other organs. This is just a glimpse of the histopathology of the spleen. The spleen, of course, has major functions when it comes to not only the cardiovascular system, but also with the immune system, and so we recognize the spleen's value. This is, of course, one of the reasons why in people they try to salvage the spleen. So a partial splenectomy is pretty typical in human medicine because we need our spleens for immunocompetency long term, whereas dogs tend not to be the same. So we tend to go with complete splenectomies, but I want to remind everybody that the spleen does provide a very important function for the immune system. Now, we're not going to have too many of these busy slides, and your proceedings has way more detail. This slide is a reminder that when you go through the literature on this stuff, it is all over the place. Depending on how the study is designed, depending on how many cases they have, and what their point of view is, it's sometimes hard to take all the data and compile them. So I tried my best in the proceedings to summarize everything for you to the best of my ability. So that's why sometimes when you see wide ranges like these, it's because the literature is all over the place because every study is constructed differently and all the different intricacies to studies like that. So in general, this is what I gleaned from the literature. As far as splenic lesions go, 0.3 to 2% of all cancers in dogs over 8 years of age. 5% splenic lesions make up 5% of all non-skin primary malignancies in large breed dogs. Cancer is found in 1/3 to 3/4 of cases. Sarcoma cases, 2.5%. Unclassified, 0.4%. Non-neoplastic, somewhere between 1/4 and 1/2 of cases. Rupture is seen in 1/4 of non-neoplastic cases, so typically malignancy to some degree is associated with hemoabdomen. Overall malignancy incidence, somewhere between 65 and 80%. Overall benign, 10 to 40%. Again, these are wide ranges with a lot of overlap because the literature is hard to interpret, but it gives you some idea, of course, that what the stats are in dogs. I don't want to forget about small breed dogs either. I've cut a handful of these in my career that turn out to be splenic neoplasia, specifically hemangiosarcoma. So small breed dogs, less than 15 kilograms. You can see hemoperitoneum. They can have malignancy because they are large breed dogs, and so don't forget about them as well. Just because they're small breed does not mean that they are excluded from this. And then again, just another busy slide. We all know that typically the splenic masses in dogs, vast majority are going to be malignant. It's not 100% though, it's not 100%, but the vast majority are going to malignancy. And we do worry about splenic hemangiosarcoma as being the most common type. But again, notice very wide ranges because studies are different. And oftentimes, this hemangiosarcoma is actually the source of the hemorrhage in surgery. You can have hepatic hemangiosarcoma, omental, metastatic disease to the liver, 1/3 of the cases. Other malignancies, 8% to 43%. And then, of course, lesser extent, benign disease. Typically, like I mentioned, splenic hemangiosarcoma is associated with hemoperitoneum in 76% of cases, whereas splenic hematoma having hemoperitoneum about 1/3 of cases. But again, these are not absolute numbers, so there's still discussion with the owners to be had. And then one final reminder, there are plenty of different splenic cancers. Hemangiosarcoma is the most popular one, it's the most common, but there is a bunch of them. And of course, depending on what you find, they all are going to have their different short-term and long-term prognoses. But we typically are looking for something that has this sort of a target lesion pattern on the spleen multifocally, but it can be quite large and very small. Hemangiosarcoma, that's a malignancy of vascular endothelial origin. It has widespread metastatic disease, poor survival, lots of different primary sites reported, lots of different metastatic sites reported. Liver, of course, most common, then omentum second, mesentery third, but it can spread anywhere. By nature, it's a vascular tumor, so therefore any part of the body that has a vascular supply is prone to metastatic disease from hemangiosarcoma. Cardiac or right atrial hemangiosarcoma is seen in dogs. You can see it in association with splenic hemangiosarcoma in 8.7 to 30% of cases. And we see this most often in German Shepherds, Golden Retrievers. They can be associated with abdominal metastatic disease as well in 30% of cases. And so I bring this up because we don't do that great of a job with screening dogs for this type of condition. Typically, and again, as a board-certified surgeon, we're being called in the middle of the night, active hemoabdomen, the ER is stabilizing the pet while we're trying to run basic diagnostics, 3-view thoracic radiographs, get the OR ready, and get in the OR to cut them. And we are, unless you're seeing an obvious pericardial effusion and pericardial tamponade on radiographs or your preoperative diagnostics, we're not actively looking for cardiac lesions in these dogs. And because most facilities are not going to have an echocardiogram in the middle of the night, and if you do have ultrasound, the folks who are doing it, including myself, are not proficient enough in these cases to find subtle changes to the heart. So I'm only mentioning this not necessarily to say that there's room for improvement, although there is. It's so that you keep in mind when you're talking to pet owners about the possibility of metastatic disease that may not be found so obviously on the preoperative diagnostics when you're going into surgery in the middle of the night. That's the point here. So keep that in mind. We don't screen these dogs routinely with full echocardiograms preoperatively. Now it might be if you have a dog that's a stable splenic mass in your practice and therefore not an emergency, you have time to work them up, and there may be the right signalment, then sure, a pet owner wants to do everything, and you have time to screen that dog, then why not an echocardiogram? Why not? But the vast majority of cases that I see as a surgeon, we're not running these diagnostics, and so just keep in mind, don't forget, it can metastasize everywhere, including the heart, and maybe we should be more proactive with screening them for this. And then, of course, when you have a dog that has a hemoabdomen for any reason, there's a cascade of events that's going to occur. It's going to affect the entire body. And so eventually, typically, depending on the case, the disseminated intravascular coagulopathy, DIC, is one of many end results for these dogs that are suffering from this, which is why, of course, we're so proactive about stabilizing them and getting them treated. We don't utilize the WHO standards in veterinary medicine, at least in my own experience with it, but it's good to know these things. It helps take these cases and objectify them, characterize them. So theoretically, if you talk to a colleague over the phone and you say something like, oh, I have a dog with stage 2 hemangiosarcoma, then they hopefully will know what you're talking about. So, but it's good to think of these things this way, even though we don't really use it practically in my experience. But stage 1 is considered localized disease, so primary tumor. Stage 2 is a primary tumor plus lymph node involvement or splenic rupture. And stage 1 and 2 make up the majority of cases in the literature. And then stage 3 is metastatic disease along with splenic rupture or lymph node involvement. This is stuff we're all familiar with. This is textbook information here. We tend to see this in older dogs. They tend to be large to giant breeds. We've got the Goldens, the German Shepherds, and others that are predisposed to splenic neoplasia. Clinical signs of hemoabdomen, pretty standard stuff. This is what you're going to see coming into your OR, or into your ER rather, and pale gums, distended abdomen. These are all pretty classic signs of hemoabdomen. You're going to run your basic parameters here. Your proceedings for this talk has a variety of biomarkers in there. And biomarkers are anything in the blood, well, anything in the body that you can measure to try and give you some indication as far as whether or not a patient has a specific disease, for example. Or maybe that biomarker predicts not just diagnosis, maybe it's prognosis. Maybe it also marks how they're responding to therapy. There's a variety of utility for biomarkers. This is, again, another underutilized aspect of veterinary medicine. Your proceedings has a bunch of different biomarkers that have been reported in the literature, some very commonplace, some more obscure, but feel free to check out those notes and see if there's anything there that calls out to you. There's a whole bunch. Most of us are at least going to run your basic chemistry panel in the CBC, and some of these parameters with a complete blood count may give you some indication as a clinician as whether or not it's going to be the higher chance of hemangiosarcoma or not. But again, these are all probabilities. They're not definite. So when you go through the proceedings and look at these statistics, keep that in mind. These are general trends that are in the literature that have been reported, but in no way am I going to tell a pet owner, oh, your dog has thrombocytopenia, therefore he probably has hemangiosarcoma. It's just probabilities. So these are all things to help educate you and the owner so they can make the best decision they can for their pet. We do see heart arrhythmias pre-op, intra-op, post-op in these dogs. We'll go over a little bit later how I tend to tackle these. And of course, because it's a systemic disease, there's a variety of different abnormalities, derangements that you can find on these dogs. The source of arrhythmias, we still don't really know, although we do have a bunch of hypotheses as to what can cause arrhythmias with them. 3-view thoracic radiographs are essential, of course, for metastatic screening. It also helps you look at the heart. I mean, is that cardiac silhouette globulate or not? Am I dealing with pericardial effusion or tamponade or not? And of course, you can see other changes, pleural fissure lines, for example. Is that a sign of metastatic disease? Is that a sign of just hemodynamic instability? Systemic inflammatory response syndrome? All the different acronyms can cause this type of thing. And so it's important to look at your radiographs preoperatively and see whether or not this is going to change what the client wants to do. Is there a reason not to go to surgery? Is there a reason to have another discussion with that client? So 3-view thoracic radiographs at minimum to look for metastatic disease, but also you're looking at all the other structures in the chest as well, so you have a more comprehensive view as far as what that patient is doing. And then abdominal radiographs is what we are going to have access to the majority of time, especially if you're dealing with this in the middle of the night. You don't typically have access to ultrasound, or maybe if you do, you can scan the abdomen for what you're looking for, whether it's hemoabdomen or other masses in the abdominal cavity. But at least radiographs can give you a hint that there may be organomegaly, soft tissue mass effect, in the region of spleen, although don't forget there are other organs that live here too. If you're a practitioner and you're going to cut a hemoabdomen, realize that if you go in there and it's a liver mass, not a splenic mass, are you still going to be able to handle that case? Or is this going to be a situation where you have to close the abdomen up? And now, sorry guys, I keep hitting the microphone. Or is it going to be a situation where you have to close the dog up and now refer them to the ER or specialty center so they cut that liver mass for you? So be prepared. This also requires client communication. You're suspecting it's going to be a splenic mass, but do you know for sure? Without more advanced imaging, do you really know for sure this is actually a splenic mass or not? It can be lymph node, GI tract, pancreas, a variety of organs that live here that can look pretty similarly to a splenic mass. So if you do cut these cases, have a backup plan. If you're in there and something gets maybe less comfortable to you, what are you going to do in that situation? Variety of other diagnostics as well that I described in the proceedings. You can check that out. Of course, the majority of us are not running CT scans or MRIs on these dogs, but again, sometimes you find these things as a surgeon, incidentally, when you're evaluating a patient for intervertebral disc disease or something unrelated, and all of a sudden there's a splenic mass there. But of course, exploratory laparotomy confirms the diagnosis, and then histopathology is key. So you don't want to go based on gross evaluation of the spleen or the abdominal organs and decide with your eyeballs that it's definitely cancer. Histopathology is what confirms it. Now, obviously, you may go in there and find there's gross evidence of what you think is metastatic disease, and fair enough, that may be what you're dealing with, but don't forget the answer is in the histopath. The biopsies is what gets you the answer for these dogs. And so you don't know until you submit these tissues whether or not you're dealing with cancer or not. It could look gnarly, it could be the biggest mass you've ever seen, it could be a severe hemoabdomen with adhesions everywhere. Until you submit those tissues for biopsy, you're not going to know whether or not it's a malignancy or benign. Keep that in mind. And this is an example of a CT scan showing a splenic mass. Again, I'm not saying this is the standard, but sometimes you do find these things that you're working up for other reasons. These are just some biomarkers that you may find useful in clinical practice. Again, these are by no means definitive, but it gives you some sort of idea that maybe this dog with these parameters, you're dealing with hemangiosarcoma. And again, in your proceedings, we go into more detail about that. The size of the growth may also have an association between whether or not it's benign or malignant, so that's also something you can look at as well. The point with all of this is because you're trying to talk to a pet owner about a life and death situation, and they're trying to decide whether or not their 12-year-old German Shepherd should go to surgery, and they just spend thousands and have this dog in ICU, and the prognosis associated with possible cancer. The reason for all this stuff is to say, well, can we tell pet owners what the chance of something is before cutting the dog, and they can make a smart decision about their pet. That's the idea here. We all know these are not definitive, like I've said many times, but that's why these things exist, to try and have a more useful conversation with the pet owner about what you think may be the case, and they can make an educated decision on what to do with their dog. Stabilization is a little bit beyond this talk, but of course you want to be aggressive when you're trying to stabilize these pets in preparation for surgery, whether you're talking about fluid therapy, colloids, things like that, and so all that has to be tackled. There's a variety of different surgeries in general. We are going to talk about the complete splenectomy. I put an asterisk here for partial splenectomy because we never, ever do this in dogs with splenic masses. I've done one partial splenectomy in my 20 years of doing this, and it was a spleen that was entrapped in the intra-abdominal hernia, and so I was fairly certain that the avascular part of the spleen, the necrotic portion, was probably not cancer, and I could remove part of the spleen. I still submitted that spleen for biopsy, regardless, because you want to make sure. Because the chances of a dog having splenic malignancy is so high compared to people, we are not performing partial splenectomies in dogs with splenic masses. You are not doing that. It's always a complete splenectomy. Always. There's very rare indications for a partial splenectomy. In people, it's different. People, they have a pretty good predictive value for scanning human beings with MRI and deciding if it's benign or not based on that. They have a very high success rate with that. We are not there yet with our dogs, and you are not performing a partial splenectomy for a dog with a splenic nodule or a splenic mass. It will always be a complete splenectomy, always. And like I said before, they don't need a spleen for normal immune function long term. You should always cut the liver biopsy for staging. Even if the liver is grossly normal, even if the liver enzymes were normal beforehand, even if it's a stable splenic nodule that you are cutting as an elective surgery, you are collecting a liver biopsy, at least one lobe. If you see a hepatic lesion and you think it's safe for you to access it, then of course, by all means, biopsy that. Otherwise, if the liver looks grossly normal to you, get a liver biopsy. You want to stage these dogs thoroughly, and that's a nice way of doing that. And it doesn't add that much time to the procedure, and so it's worth doing. Now, if you have a dog, if you have a situation where the client is literally barely able to afford the surgery, and your goal is just to get in there and get out, just to get this dog out of a crisis, then for financial reasons, sure, we can forego this, especially if the liver does look normal. But in general, in an ideal scenario where that is not the problem, you're collecting liver biopsy. Do you perform a prophylactic gastropexy at the same time? So this, in addition to any other diseases that this dog has, maybe it's got bladder stones along with a splenic mass, maybe it's got a mammary gland tumor as well, whatever it may be. Maybe the owner is like, hey, while you're there, can you do a dental? This kind of stuff, these little add-on procedures. I'm okay with them as long as, when I talk to the pet owner, I tell them I have the ability, I have the right to abandon any procedures that I feel are not necessary to save this dog's life. The goal is to save the dog's life. The spleen comes first, or whatever is causing the hemoabdomen. All this other stuff would be nice to do, not just from a medical standpoint, but of course financially. But I'm not going to risk the dog's life to do this. So I get the permission beforehand that I can abandon whatever ancillary procedures I want if the primary goal cannot be achieved safely. The dog's well-being comes first. That's why I handle these discussions. So no, I do not pexy every single splenectomy that I perform. It depends on whether or not the animal is stable enough to survive it. Even though a pexy in my hands might add 10 minutes to the procedure, that still might be too much time for that dog who's grossly unstable. So that's how I handle sort of optional elective type procedures. And then if I can't do these things, then sure, once the dog survives this procedure, we get the biopsy back, and then in the future is planned that cystotomy for those bladder stones or whatever it may be. Keep in mind, most of these dogs are going to be large breed geriatric dogs. They're going to have a bunch of other problems. They're going to have arthritis and endocrine diseases and what have you. And so all this stuff is important to discuss with the client as far as the prognosis overall, not just intra-op, but then of course post-op recovery. You want to make sure with these dogs, for example, I've had dogs where you tie them on the table, and then once they wake up from surgery, they basically are now T3 L3 myelopathy because they did great from the spleen surgery, but you stressed out their spine, that was riddled with arthritis, and now they can barely walk. You have to be aware of these things when you're dealing with this demographic of patients. So different surgical techniques, these are just, I'm just being thorough, that's why I even have these here. But our goal, of course, is going to be the complete splenectomy, and there's a variety of different ways of performing this procedure. I am a huge fan of ligature. It's almost like cheating with surgery. It makes surgery so easy. It's a bipolar sealing device. I don't know where the market is now with these devices, because we just keep reusing them. But there's a variety of different tools, surgical tools you can use. Everything from just old school sutures to a variety of LDS staplers, things like that. Whatever your practice is comfortable with and wants to use. But for me, obviously, you're trying to perform these procedures as quickly as possible. So any kind of bipolar sealing device, it just cuts through the vasculature. It's so efficient. I absolutely love it. If you do a lot of spleens and you can invest in something like this, it's well worth it in my opinion to do so. A quick mention of splenic torsion. I've seen maybe 2 or 3 in my career. It's not that common at all. But just for those who are cutting spleens in this room, if you see this, splenic torsion, you're not going to unravel it. You're going to remove an end block. You do not unravel these, otherwise you're going to have a storm of free radicals and all the horrible effects of systemic and inflammatory response from it. So just as a reminder, splenic torsion, you're going to try and remove an end block and not, of course, try to not affect the other organs, nearby organs that are sharing blood supply. But just a reminder, they're not common at all, but it's just a point to make. And then just to show you liver biopsies, variety of different techniques, everything from a dermal punch biopsy to guillotine method. You can use a ligature device as well, whatever technique you want. Get good liver biopsies. That way, when you are in a hemoabdomen, you can collect that liver biopsy quickly and not add significant time to the anesthesia and surgery. I do want to point out these types of products. So these are coming out more, and of course, Zomedica is sponsoring this talk, and they are at the forefront of products like these. I love this stuff. So Vetigel is their product to help with hemostasis. There's a variety of benefits to it in terms of its molecular makeup, but I have here other indications for it. And I'll show you this video of using Vetigel. Definitely visit their booth in the exhibit hall and talk to them about this type of product. This stuff is awesome. Of course, we're focusing on spleen and liver here, the liver biopsy, but it makes this so hemostatic technique so much more efficient with these animals. It's phenomenal. Things like gel, I've had problems with gel foam in the past, and sometimes you're trying to biopsy a liver lobe that's not in the process, in the periphery, in the body of the liver. This stuff is really, really useful. So easy to apply and so quick. So please visit their booth and talk to them about Vetigel. It's phenomenal stuff. Post-operative care. So in an ideal scenario, I think you're dealing with a hemoabdomen that had to be stabilized and then had a splenectomy. You want 24-hour care. And so in an ideal world, they would be in that intensive care unit, ICU, 24 hours being monitored. Ideally with your electrocardiogram, I think continuous is the way to go. If you can't do continuous for whatever reason, or maybe the animal's not tolerating it, you don't have the equipment for it, whatever it may be, then at least spot checking in the hospital every 6 to 8 hours is ideal. We know that without continuous, you're going to miss some cardiac arrhythmias. So if you can get away with continuous, great. But you want to monitor ECG, pre-op, intra-op, and post-op. Same thing goes for blood pressure. If you can do a continuous blood pressure on these dogs, great. If not, every 6 hours. If you diagnose hypotension in these dogs, then you try to correct hypotension with fluid therapy or whatever it may be. Check the blood pressure after you're done with the bolus. Check your blood pressures. I know plenty of clinicians that will diagnose hypertension, they try to correct it, and they don't check blood pressure afterwards. It's the same thing with ECGs. If you're treating for an arrhythmia, well, you need to monitor that heart for your response to the treatment for arrhythmias. So be proactive when you're looking at diagnostics for these dogs. They can change really quickly, and when they change quickly, you can fix a lot of these things, but you have to identify them. PCP total solids checks depends on the case. A really bad hemoabdomen, obviously you've hopefully collected this pre-op, but intra-op too, if it's really bad, there's a lot of hemorrhage, I'm having a difficult time, maybe the dog is somewhat coagulopathic, I'm checking PCP total solids intra-op. Otherwise, I typically will check it. If it's really bad in surgery, I'll check it right after surgery. If surgery was great and went really smooth, then maybe I'm checking the PCP total solids about 4 hours post-op, and then maybe from there, it depends on the case. There is such thing as checking it too often. You don't need hourly checks unless you have a reason to. But typically with these dogs, 4 hours post-op, and then maybe it's going to be every 8 hours, every 12 hours, depending, then it goes to every 24. That's typically how it's going to go if these dogs are recovering as expected from surgery. So packed cell volume, total solids checks, very important. These dogs are going to be old and arthritic, like I said. They're going to have other issues, hypothyroidism, diabetes, whatever it may be. They're going to be recumbent because they came into you unstable hemoabdomen. So it's important that if they are not ambulatory after surgery, to try to keep them sternal. If you keep them sternal in their run, in their cage, it increases tidal volume. Increasing tidal volume helps prevent things, hopefully, like bronchopneumonia, hopefully helps prevent things like pulmonary thromboembolic disease. You want to get them to walk, get them walking. One of the biggest factors in dogs and people for thromboembolic disease, pulmonary thromboembolic disease, PTE, is being obese, overweight, and being stationary, not being mobile. You don't want to force the issue. The dog is obviously critical and anemic, having arrhythmias, they're going to have a hard time walking, so you don't want to force it. But you want to have some sort of mobility. At minimum, if you can, they can maybe walk around the ICU unit, or they can't even do that, gurney them outside, put them on some grass, and then gurney them back in. You just want some sort of upright positioning and movement with these dogs. Analgesia, of course, very important. Keep in mind these are going to be old dogs with other comorbidities. They're very sensitive to narcotics and opioids. Yes, some of them are reversible, but you prefer not to overdo it accidentally. And if you're dealing with a dog who's somewhat critical, but you also want to focus on analgesia, these pain meds can be a lot on them. So maybe start low and work your way up as far as dosing. Maybe spread out the frequency and then go more frequent if needed. Perhaps you're giving some of this intravenous and maybe half dose IV, half dose sub-Q. Do something to try and deal with the fact that these dogs are old and debilitated, and so these drugs are awesome, but you also don't want to overdo it. Keep that in mind. And then eventually they start eating. You can switch switch them from intravenous drugs to oral. In terms of cardiac drugs, so again, this is going to be a boarded surgeon talking about cardiac. So you may have internists that are going to shake their head on this kind of thing. But this is how we did it in Long Island Veterinary Specialists with our internists as well. So if there's a ventricular tachyarrhythmia with these dogs, we're going to start lidocaine, using an IV bolus of lidocaine followed by a CRI. You'd like to see them cardioconvert when you first give the bolus. They may not always do that. So IV bolus, CRI, and then we're starting with something that's going to help them longer term than the lidocaine, and so we're typically starting with procainamide, intramuscular at first, because these dogs, again, it's right after surgery, so they're not eating right away, but I want to get the procainamide on board while the lidocaine is doing its thing. And then once we transition from IV drugs to oral, we then can get them off lidocaine and get them on procainamide. But lidocaine has a bunch of positive effects, but also it does cause nausea, causes ileus, causes neuromuscular weakness. And these are dogs that are very debilitated for all the reasons that we've mentioned. So you want them on lidocaine, but also off as quickly as possible. And as far as I know, working with internists, you don't have to wean them off lidocaine. You can stop it cold turkey. But you have to realize that this drug is potent, and I want them off of it as soon as possible, as soon as I'm able to, based on, of course, their response with the cardioversion. Hospitalization duration depends on the case and your facility. Maybe you're cutting the dog, stabilize them, and they go to an ER for the overnight. Whatever your relationship is with your local ER or specialty hospital. Typically they're in the hospital for at least 24 hours for your stable elective surgeries, but longer if they became critical. And then, of course, close watch on them as they're old and trying to recover from a major procedure. And then this is another role of mine, which is telehealth. I love this stuff. And again, kudos to Zomedica for inventing something like this. I'm a big fan of tele-anything, and telediagnostics, telemonitoring is huge. We know this now for folks who manage diabetics at home, right? You have these diagnostics now that can measure blood glucose values continuously, and it's uploaded in the cloud or an app or whatever. And so the VetGuardian device is what Zomedica invented. I've used this before in my own cases. It's phenomenal. So it's the intent here is to not have to lay hands on the animal all the time. These are debilitated animals. Maybe some are aggressive. Maybe some are very sensitive to stress and anxiety when you interact with them. You want diagnostics that doesn't add to that stress. And you also want to make sure that your staff is tending to other patients who need their hands. If you can monitor a patient virtually or from a distance rather, then diagnostic like this is fantastic. So it measures vitals, body temperature, uses thermography, pulse rate, respiratory rate, movement. So it has a thermography camera. You can also switch it over to a live camera, depending on what you're looking for here. And all this stuff is done from a distance. So continuous telediagnostics. This stuff's the future. This is only the beginning of this. We are going to see a world of telediagnostics that are going to be it's going to change the profession in terms of managing, monitoring critical patients. It has a bunch of benefits, not only for the pet, but for the staff as well, and it's quite literally the future. And then VetGuardian has upgraded their the product to now VetGuardian Plus. So much sleeker design, much sturdier handles here that you're attaching to an IV pole or to the front of a cage, and then a screen on the back as well that gives you a summary of those vitals that it's measuring. I love this stuff. Visit their booth and talk to them about this. This is going to be the norm in our profession. This is showing you can have multiple animals hooked up to VetGuardian Plus at one time, and so all these animals can be monitored on an iPad or a phone for these cases. And of course, they're great for hemoambulance because these are dogs that typically require continuous monitoring. And if you're cutting these cases, especially if you're in a busy ICU, you don't have the staff always to watch them. So VetGuardian Plus, go to their booth, ask them all the questions you want. This is phenomenal. The outcome of these dogs, similar to other publications, can be all over the place depending on how the study is formulated. So this is just I tried summarizing this for you. For hemangiosarcoma specifically, mean survival time, if you go based on the WHO staging procedure here, stage 1, 151 days, stage 2, 107, stage 3, 73 days. Obviously, none of these are great, but certainly the lower the stage, the better the prognosis, but you're talking about a matter of weeks to months with these dogs. If you look at both stage 1 and stage 2 dogs, 50 to 75% within 86 days are going to survive. 1 year survival, very, very low, 6%. Of course, benign, they live longer, obviously, 650 days. on average. 1 year, they're alive at 85%, number alive at 3 years, 45%. Malignancy, of course, much less. Notice this is malignancy, not necessarily hemangiosarcoma. That's why you're seeing longer survival times, because not all malignancies have the same horrible outcome that hemangiosarcomas do. Hemangiosarcoma cases, 30% will survive 2 months, 7% survive 1 year. And I've had cases where they're 5 years post-op hemangiosarcoma. And I wonder, well, maybe the original histopathology was just wrong. And I'm sure that happens. It's hard. You're giving the pathologist an entire spleen, and you want them to diagnose something that's vascular, and they're not going to go through every single slide. They have to pick representative samples. And so if you ever get a case, and this doesn't apply here, it applies in general to biopsy cases. If you get a case where the histopathology doesn't really match the actual case itself, ask for a cut in all wet tissues. Have the pathologist go back to the wet tissues and cut new samples and reevaluate it. It's fine to ask that. Don't go just based on it because the histopath and they know all, which they do. But double check. If it doesn't match the case, then ask them to cut in all wet tissues and get a not a second opinion, but a reevaluation on the diagnosis. So I've had hemangiosarcomas last much longer than they should, which is of course great news, but then I doubt what the initial diagnosis was. And then chemotherapy will prolong it after surgery, of course, for the right owner and if you have chemotherapy available. I'm going to revisit again the VPC, ventricular premature contractions, because a common question I get is when do you treat them? When do you treat VPCs? So there's 2 parameters where I consider worthy of treatment. One is if the dog is clinical for it. So it doesn't matter how bad it is on an ECG strip. If I have a dog that's got drop pulses, pale gums, very weak, labored breathing, and all the other reasons for those symptoms I've ruled out, then maybe the occasional arrhythmia this dog is having is significant enough for that dog to affect him. Or maybe I'm missing VPCs, so I'm not running a continuous ECG on them. So if the dog is clinical for it, and I believe the arrhythmia is the reason why they're showing those symptoms, then I'm going to treat it. The other parameter that I use is, roughly speaking, if I'm seeing the VPCs take up about 30% of a 1-minute strip, 25-30% or more, then I treat them. And that's irrelevant to whether they have clinical signs. So if they are affected by VPCs that make up about 25-30% of their strip without clinical signs, I'm going to treat them. Or if they have clinical signs associated with VPCs, regardless of how severe they are, I'm going to treat them. That's typically how I'm going to go about it. And the ideal, of course, is that you convert them to normal. You may or may not get that. It depends on what the dog wants to do. But your goal is to be proactive with this stuff so that it doesn't add to the comorbidity with these patients. Prognosticators, there's way more than this in the literature. I have summarized in the proceedings. I just picked a few that probably more common sense stuff. If the dog is being affected systemically by this disease, pre-op, intra-op, post-op, and of course the prognosis may be worse. We already saw stage 3 dogs have a worse prognosis and other parameters as well. And so these are all just things to look at that help you and help you talk to the pet owner about prognosis with these hemoapneias. So some key points. The splenic literature I mentioned. I tried summarizing for you. It is difficult, so if you find yourself frustrated by reading publications, that's why. There's very different sizes, different structure to the papers, so keep that in mind. I tried summarizing it for you, but that's me doing it. Client communication is key. When you talk about all these prognosticators, when you talk about all these potential complications, the recovery time, what the treatment plan should be, all these different things ought to be discussed with the pet owner. And I will also say too, if you go into surgery and you find out that something is not what it ought to be, you can call the owner intra-op. I call owners intra-op all the time and say, hey, I found X, Y, and Z. I'm in surgery now with your dog. Here are your options. What do you want to do? We have to make a decision right now, right? And so these are conversations I have with the client. If I went in there and it's not a splenic mass, it's a massive retroperitoneal mass, and now the dog requires a total nephrectomy. I gotta call the owner, tell them, look, it's actually not a splenic mass. We're actually talking about removing the kidney and the adrenal gland on one side. Are we good for this? I have to decide right now, and so these are things you can do with the client communication. That's all clients want. They want you to communicate with them, and that's what avoids frustration and emotions from it. Always biopsy the spleen. Always, always, always to confirm the diagnosis, and you're always going to collect a liver biopsy, and you're not going to perform a partial splenectomy ever in case of splenic masses, ever, ever, ever. And then we mentioned concurrent surgical procedures, reserving the right to abort mission if you feel that those procedures are not going to be to the benefit of the dog. Now you might say, well, what if the dog gets a GDV later on? Am I liable for it? That's the importance with client communication. The ideal scenario is you PEX them at the same time. We know that dogs that have splenectomies are at higher risk of GDV. However, again, I'm not going to risk the dog dying from hemoperitoneum now because I added 15 more minutes to the procedure. So yes, discuss these cases with the client, but they have to also understand that you have the right to abort. Also, this all should be documented in your medical records. You can talk to them about all these different things, pros and cons, and they understand everything. This has to be all documented in your medical records. I want to thank Zomedica again for sponsoring this talk. Please go to their booth. They have some amazing stuff, cutting edge products that I stand by. I love it. This is my contact information here. If anybody wants to reach out to me after this talk, if you have any questions or what have you. And for those who want to know more about my company, that's my company there. I'm happy to take any questions that anybody has. Thank you. Yes.
So you said prognostic here, thrombocytopenia. A lot of them are consumptive. Is it like below like 30K or 60K or something?
So the question is, when you look at prognostic indicators, thrombocytopenia is one of them. These dogs will frequently have low platelets because of the nature of the disease, right? And so our question was, is there a certain number of platelets where you worry about prognosis? So for me, in terms of, all I care about with this is, can I cut the case or not? Can I cut them? So if I have low platelets, but the dog doesn't have any signs of a coagulopathy, and again, you could argue, well, what happened could be a sign of coagulopathy, sure, but I also have a partial splenic mass, so that explains that. If there's no ecchymosis or petechia, then I'm gonna cut the case, and I'm not really focusing on transfusing with blood products to make up for this or any sort of hemostatic intervention. So for me, no, it doesn't matter. If I do see signs of DIC or what have you, well then I'm talking to the pet owner about, we also need plasma transfusions and all this other stuff. We have to try and stabilize his pet, but we still have to cut them though, because they're bleeding from a splenic mass. So you're tackling multiple things at the same time. At the same time, but that's the importance of client communication. So for me, no, if there's no signs of coagulopathy, but they have low platelets, I'm still cutting them because I'm going to assume those low platelets were not there before surgery, and it was a consumption thing. Whereas if they're symptomatic for it, then I'm going to be probably talking internal medicine if it's not in the middle of the night and getting their advice as well. Any other? Yes?
Recognizing that this is going to be a tough question, if you have a golden retriever that's lucky and prophylactic gastropexy, can you take a spleen out at the same time?
If you're cutting the case for a pexy and you find a splenic mass,
Your dog is in for a spay, where I practice as a trend now because the dogs are at risk of doing gastropexy. Recognizing that this is a vascular tumor and it hurts other organs, would you consider doing a prophylactic splenectomy as well?
okay. So the question is, and tell me if I'm wrong, you have a golden retriever, you're going to go spay her, and you're going to also perform a gastropexy. Knowing that golden retrievers are at a higher risk of splenic disease like this, do you prophylactically remove the spleen at the time of the spay? No. No. It's kind of, the way I would think about it is, am I going to perform a TPLO with every single dog that's prone to cruciate disease, right? Just to do it, just to change the angle of the tibia to prevent cruciate disease later on. No, I would not. I would not recommend it. Number one is if you're dealing with a juvenile patient, then they still need the spleen for maturation for the immune system. Number two is you don't know if that dog's going to have splenic cancer in the future. And number three, you know what will happen. That dog will get hemangiosarcoma in the liver or something when it's 11 years old, and you're like, So no, I would not recommend prophylactic splenectomies for these cases. I know that folks that are treating like IMHA cases or what have you will do that as part of their regimen. That's kind of beyond my expertise, but no, I would not recommend prophylactic splenectomies. You want to have a reason for it.
What about prophylactic lidocaine? Better Dennis Crowe used to report that this is a great way to do it. We do it all the time. We do a lot of TVs and we're giving the lidocaine free up of what they have diseases on.
Yeah. So the question is, would you prophylactically treat with lidocaine, for example, in a case that's prone to VPCs or cardiac arrhythmias even before they have them? I personally would not do it. Now, obviously lidocaine is also analgesic. And so if you're implementing that as part of your multimodal approach to analgesia, and it just so happens that you're dealing with a vascular case, then sure, I'm okay with that. But I'm not sure I would. Does anybody else here utilize lidocaine in this manner, just prophylactically? Yeah, I'm not sure I would for the indication to prevent potential cardiac arrhythmias. I think if it's part of your analgesia plan, then great. But otherwise, no, I probably wouldn't. But I don't have a better reason other than the side effects of lidocaine to me when they're awake is somewhat compromising. If I don't need to use it, I don't want to use it. But yeah, but I can't give you. That's my thought. More my opinion. Yeah. Yes.
Thoughts on if you have a significant hemoglobin and you're trying to leave as much of the blood in the abdomen as possible, yet suction it up to visualize reverse metastasis?
So the question is, if you have a hemoabdomen and you want to remove enough blood to do a full abdominal exploratory, but you also want to leave some blood in for reabsorption purposes, how do you balance that? I don't leave any blood in. And yeah, so the reason for that is, number one, I'm not convinced that it's a significant source of red blood cells to help with an anemic dog. Number two is, I've had surgeons that do this, and the weight of the fluid in the abdomen starts seeping through the incision, and I have a leaky incision, the dog has got some abdominal distension, and I don't know whether or not it's a failed surgery or if it's leftover blood from the hemoabdomen that I decide to leave in there. I want to know if my hemoclip, my suture slipped, and now there's a hemoabdomen from my surgery. I want to know that, and so I wouldn't. I would err on the side of empty the abdomen, have other ways of transfusing that dog, and then do your thorough abdominal exploratory that way. Yeah. Yes.
I feel like more genetic hemoabdomens and chronic ruptures, but what about putting belly band on early on to decrease bleeding?
So the question is abdominal bandages to try and help minimize the bleeding. She made the comment that she sees a lot more traumatic hemoabdomens than splenic masses. For traumatic hemoabdomens, I have done that before, and I found it to be somewhat annoying because I also want the staff to monitor this dog's respiratory rate and effort, and the bandage gets in the way of that. Also, bandage complications too. These dogs are older and debilitated. They're peeing and pooping in their cage and on the bandage, and you have to now schlep them out of the cage and do the whole bandage again, or what have you. And the bandage gets put on badly. I've seen it. If it's not done in a cross your heart bandage type fashion, it slips down to their groin, and now it's useless again. So I haven't found much use for it in terms of traumatic, but I understand the reason for it. And beyond those inconveniences, I have no problem with it. As far as hemoabdomens go, I maybe there's a reason why you can't cut the dog that night, maybe, but I'm not even sure I would even do that. Because of all the reasons that I mentioned, especially if it's an active hemoabdomen from a splenic mass, I'm not sure it's worthwhile doing. Do other folks here use like belly bands or abdominal bandages? You do? And for hemoabdomens in general, or does it depend on the case? Depends on the case. Yeah, so that's my opinion on it, but I can't back up with any kind of literature. That's just what I've seen from trying it, Any other questions? Yes?
Are you offering any other lectures?
Am I offering any other lectures? Yeah, so thank you. So tomorrow, I'm giving a talk on alternate career paths, because I'm a board certified surgeon that then went to telehealth full time, and so feel free to join that. And then later on, I think tomorrow, there's a panel discussion, me, two other doctors, and then Dr. Adam Crispin from DDM 360 will be moderating it, and we're doing a discussion on alternate career paths as well tomorrow. Yeah, so for today, no more talks for me, but tomorrow we have two. Thank you for asking, and I hope to see you guys there, of course. Yeah. Thank you guys. Thank you.
Great lecture.
Thank you.
Tomorrow, but
I don't know.
Okay,
Yeah, I
okay.
don't. But I was working towards, that. But for veterinarians who work for the platform, it depends on how active they are on the platform.
Yeah.
And 1/3 of them do it kind of full time, but also retired and sort of
Yeah, yeah.
fun. The other 2/3 doing it for like side income,
Okay.
but they're still working brick and mortar.
Okay.
So to me, at least based on how telehealth is set up now, if you want to do it for a full-time gig and you want to be really active, you can make 100,000 with it.
Okay.
It's not going to match what you can do in practice.
Yeah.
It's really more production, right? But the benefit is you're working from home and there's no diagnostics, no surgery, there's no,
Yeah.
you're just at home on a laptop. Talking. Vet triage.
That triage. Okay, so
Oh yeah, I'll give my card. Yeah. But if you're interested in that, there's a little email on the site, and just let us know if you're interested.
yeah, sorry.
Yeah.
Sadly, was spending more money than I
We'll go
have.
through more details and I'll go to Zoom call. Yeah.
Thank you.
No problem. Nice to meet you. Hi. Yeah, you look familiar. Good to see you.
You look familiar.
How you doing?
I'm good. Are you still in the Bay Area?
I'm in Vegas now. I live 20 minutes from here. Yeah. Yes. Yeah. I didn't enjoy living in the Bay Area. I thought it was boring and
Really?
gross. Yeah, I don't know. It was just a lot of poverty, a lot, I don't know. I couldn't do it.
I guess it depends on where you are.
Of course. I was in downtown San Jose.
Okay.
I just walked out like, oh my God, why am I paying $3,000 a month for a small apartment? And it sucks, So it wasn't my style.
Yeah.
Vegas is much more my energy level. Lifestyle.
I think Vegas is much better.
Yeah, most people stay like, a weekend and I'm good. But for me, I was hooked on it. I loved it. And I'm not a gambler or anything. I like the energy and the versatility, and everything's 24 hours and it's so cheap to live here. So California is, a flight away. Yeah, good to see you too. Thank you.
I can see why your energy matches Vegas.
Yeah.
I had a question kind of along the spectrum of care lines.
Yeah.
I work in a rural practice.
Yeah.
2 doctors, 1,500 people in the town.
Yep.
Our nearest 24-hour ER is like a 2-hour drive away. So we haven't seen the hemo abdomen yet since I've been there, but I know it's going to happen eventually.
Yeah.
What are your kind of minimum standards? What would you say we could think about doing in our practice versus what should be euthanized or?
So first, if you have the ability to practice splenectomies on a cadaver, whether it's euthanized animal or from like a local shelter that you have an agreement with or whatever, practice these in a normal scenario. Of course, having a big splenic mass with omental adhesions and hematomas and blood is different than like a nice controlled, cute little spleen, right? But so there's going to be still a shock value when you cut an actual hemoabdomen, but at least you can get accustomed to the anatomy there, right, and the approach and all that stuff.
Yeah.
Then decide how you want to do it. If cost is a factor, then you can standard suture. It's basically just a glorified spay at that point. It's just a bunch of sutures. But if you start getting really cool with it, you can do more fancy stuff. And then your post-op diagnostics, because it sucks to have a spleen surgery go great, but because you're not checking blood pressure or ECG, the dog dies overnight just in his sleep, and you're like, what happens? We're doing great. Well, there's no monitoring involved.
Yeah.
So have anything for blood pressure, ECG, and then whether or not blood products, I don't know how heavy duty you want to get into it, whether you want to have some pack of blood cells on hand or not. I don't know the shelf life of these things. Whenever I worked in practice, you go through them, so I didn't really care.
Yeah, we don't have anything like that right now.
Yeah. And if you want to set up like a blood a donor system, maybe staff has like a healthy, but again, I don't know how much a pain in the ass that is to collect blood, but you could. I've had hospitals do that. They'll collect blood, whole blood, to then give to the patient, for dogs that are screened beforehand.
Okay.
So you can set that up too. I just don't know how annoying the setup that's going to be for you, but it's again, it would suck to have a splenectomy die on you when you could just maybe one transfusion would have done it, got them over the edge,
Yeah.
I think those are some things.
Okay.
Have large enough formalin jars,
Yeah.
because that also is going to be a factor.
Our overnight monitoring is me coming in the middle of the night. So
You're spot checking them throughout the night, or
basically, if that were to happen. So Q6 hours, I feel like is still not enough in these post-op cases, but I guess if that's what we have, then
yeah. Well, so at some point you have to do whatever you can, right? So if the client understands they can drive 2 hours away and get all this fancy care, or you'll go for it, right?
Yeah.
But the monitoring is less and all that stuff, and they understand that. And most owners are very appreciative. I prefer to have a dog that gets a chance as opposed to just, well, we have to euthanize it because we don't have overnight care here. Screw that. Cut the case, stabilize it, do the best you can. At least it gives the dog a chance. The owners are up for it. They understand that there's limitations. Then I don't like the idea of euthanizing a dog that maybe could have lived at least a month or two. You've been happy, or maybe it's benign. You cured them, right? So I would that conversation is important to have with them. Like, there's levels, and that's the whole spectrum of care you're talking about.
Yeah, for sure.
Depends, yeah. And it's not always financial. So, like with vet triage, for example, we work in areas that are way more remote even than yours are. And so, like, here's what I would the best. Here's some in the middle, and here's like, lowest tier of care. They can decide what they want based on their own beliefs and finances and everything else.
Okay.
Yeah. But I think those are some good points. See if you can get a cadaver and practice it. Start there. You've done no splenectomies yet yourself?
No.
Yeah.
I saw them in school, but I didn't actually do them. So.
Yeah, that's good. Again, you'll be shocked at the amount of blood that's going to come out, right? And all the adhesions. You're going to be like, what the fuck am I into? But again, remember, you offer them the specialty or the ER. They can't do it for whatever reason. This is you doing your best to save a life. And then once you see that ugliness, anything else will be easy.
Fair.
It's going to be easy.
Yeah.
If you cut them, will you have somebody scrub them with you? Technician or somebody, another set of hands? Probably good idea.
Probably would have the other doctor there.
Or do you have Balfour retractors?
I think we do. I have to check.
So if you're gonna dive into them, trying to get at least one pair of large self-retracting Balfour retractors.
Okay.
Then you may not need an assistant to scrub them, especially if you have a small team. The Balfours are fantastic, and by the way, you can use them for your big spays that are always kind of scary people. I give a talk at Pyometras, and I always have slides on like, by the way, have Balfours available. Why are you guys struggling with these huge dog spays and then ovarian remnant syndrome, and you're freaking? It's a 3-hour spay, right? All because you didn't have the abdomen open. So if you can't have anybody scrubbed in to hold the belly open for you and retract organs, then at least have a retractor, Balfour retractor there.
Okay.
Yeah. So those are some ideas.
Cool.
Yeah, of course.
I also wanted to get more information about the vet triage.
Yeah.
Because that sounded interesting too.
It sounds like the location of your practice. Where are you guys located?
Vegas, Colorado. It's right there in Durango, some corners. Yeah.
Awesome. Yeah. So the idea with vet triage, we partner with hospitals, and we provide either during hours or after hours triage. So when you guys are closed, and instead of having every single client freaking out at home when they have to either decide, do I drive 2 hours or watch my animal suffer, I don't know what's wrong with them, they talk to us instead.
Okay.
It's free for the facility. It's 24/7, doctors only, live video. The client pays $50 for anything that's not a horse, $75 for horses.
Okay.
We triage the patient. They can spend as much time on video with the doctor as they want. We get the whole history, look at the pet. We do a physical exam with the owner's hands, and then we give them advice. Do you have to go to ER or not? 80% don't. So we give advice, monitoring parameters, make them feel good, and they have free follow-up with us until you're open again.
Okay.
So if that dog's diarrhea turns into an HGE, we want them to tell us that. If that dog's vomiting turns to a GDV, we want them to tell us that. So they can follow up with our vets by phone or email after the video session for free. And then you get all records. The records will be date and time stamped when the session ended. So when you guys open the hospital the next day or the next week, you have an inbox full of the triage reports. And then your staff can call Fluffy, hey, I heard Fluffy saw that triage for limping on Saturday. Yeah, he jumped off the couch and so, oh, my husband's doing now, he's much better, but he said I should come in and get x-rays. Yeah, let's do this Thursday. Sounds good, right? Everybody has to follow up with somebody. They don't stay with us.
Okay.
So all the ones that don't go to ER come right back to you. And you'll have reports to follow up with them. If you do need ER care, we call them in.
Okay.
You're going to call ER and say, hey, look, this is a back dog. It's a down dog. Are you guys okay with that? Should we go somewhere else? Should we go to the university or whatever, No, we can handle back dogs, okay. And then we'll call them in and tell the client, head on over there.
Okay.
So we want to take care of your client regardless of the outcome. Most people don't have to go to ER.
Yeah.
Yeah, so if you want to set up, what I can do is give you my card. Oh yeah. I know, already we get them.
Prepared.
There's a Google form that I'll have you fill out. It just talks about your hospital, like during hours, after hours, how can we take care of your clients for emergencies. You fill it out, I'll edit it. If I have any questions, I'll ask you. Otherwise, once the protocol is finalized, which is the Google form, I'll build for you flyers. They're flyers that have like your logo on it and a QR code. You can hand it out to clients at checkout, or you can share it on social or email to them. And I'll also build for you a landing page. So like vettriage.com/Main Street Animal Hospital. You put it on your website with the Vet Triage logo, and then clients can access us either by clicking on the logo, and they can create an account. They wait a minute and a half to talk to a doctor on average. Or they can call us if they don't have internet. They can pay over the phone and talk to our doctors on the phone too. But 90% of them need video calls. So we'll build all that for you for free, and you just fill out the Google form, and then I'll take over from there.
Great.
Yeah.
Awesome. And I heard you talking to someone else about opportunities for vets to do
Yeah.
this kind of on the side,
Yes.
part-time too.
So if you're interested in that also,
Yeah.
when you email me, or you can text me too, whatever you want, but tell me that you want the Google form, and then tell me where to send it, what email, and also you're interested in interviewing, and I'll set up a Zoom call with you.
Okay.
I'll ask you for your resume, because I have to, and then we'll set up a Zoom call. I know, I hate it. So I'm dealing with doctors, it's like not, But anyway, it's about a 45-minute Zoom call. We'll go over all the intricacies of working with the company and see if it's for you or not.
Okay. Perfect.
Yeah, just reach out to me and I'm happy to hook you up.
Awesome. Well, thank you.
Nice to meet you.
Nice to meet
Pleasure,
you.
Doc. Thank
Yeah.
you.